Okay, so I'm going to finish the shoulder lecture for the last 10 or 15 slides regarding the upper extremity PT 652. Sorry I ran over. I'll learn to try to focus a little bit more. So the superior labral lesion is the last component of the subacromial pain area. I want you to think about is the labrum a static or dynamic stabilizer. Obviously, it is a static stabilizer. So the type of tests that you would need to do would be which type, active, passive, or resistive. Since this is a static structure, you're mainly going to do active and passive, primarily passive type of range of motion test. So the typical clinical presentation of somebody with a SLAP lesion is middle age. They might describe some clicking or catching. About half the patients present with this. This is an important question to ask, as it is helpful in the assessment of this pathology. They may or may not have limited range of motion or very slight loss of range of motion. About a third of these patients have reported falling on outstretched arm or receiving some kind of blow to a shoulder, so some type of trauma. About 20% of the patients report an episode of a subluxation or dislocation in your arm giving way. About 15-16% report symptoms after they were doing a heavy task, or maybe they were trying to lift something, it slipped, and they tried to grab it, sort of decelerating that activity. A relatively small percentage report insidious onset, and in this study, only about 12% of the patients were due to overhead activities like throwing and tennis. They reported not so much of a trauma, but just inability to control where they wanted the ball to go. Maybe noted that it was hard for them to get their arm loose, or they were having some biomechanical changes. So as you go through the examination for SLAP tears, the orthopedic surgeons divide these into 4 SLAPs, but our clinical tests are not that sensitive to separate what is a type 1, type 2, type 3, type 4 SLAP. So it's basically you're looking to see if there is or is not some kind of labral pathology in your examination. So from the literature, a recent publication out of the American Journal identified that these tests in the green were important and helped identify patients that might have a superior labrum. So they looked at history of trauma, history of popping and clicking, the active compression test, also called the O'Brien's test, the anterior slide, and the crank test. And in 55 patients undergoing superior labral pathology, they were able to identify a certain percentage of those patients. So the anterior slide test was created by Dr. Kibler. Hand is on the hip, thumb facing backwards, and basically axially loading the anterior aspect of the shoulder. So basically pushing the humerus up and superiorly, and it's positive if that reproduces the pain. And maybe you'll feel the patient will have a painful click, but it's more common to have pain with that, typically in the superior aspect of the shoulder. So the specificity of this test is pretty good. It's been looked at by several different studies, 5 different studies, so you can see it's consistently pretty high specificity. The QUADIS score is just the critical appraisal score, and the higher that number is, the better. A top score is like a 12 on that. The crank test is the other test that was used in this study by Walsworth. Basically, the arm is elevated to about 160 degrees. You put an axial load, and then you maximally internally and externally rotate it. Again, you're trying to have a reproduction of symptoms. There may or may not be a click, so you don't have to have a click for that test, but you're looking for the reproduction of symptoms. Again, this is had a wide variety of sensitivity and specificity. So by itself, it's not as helpful, but in combination with these other tests, it's helpful. The active compression test, also called the O'Brien's test, when he originally examined it, he found really good sensitivity and specificity with that test. The pictures illustrate the two test positions. The first test position is with the thumb internally rotated, arm right across the shoulder, and ask the patient to resist your downward force. The second position is with the arm maximally externally rotated or palm up in the same position, and again asking them to resist that. A positive test is pain in the first position and reduction of pain in the second position. When O'Brien originally described this test, he talked about it as both an AC joint test and a labral test. So when you ask the patient about their symptoms, if they're focusing more on their AC joint and more superficial, that would maybe indicate an acromioclavicular joint injury. If it's deeper or more general sensations, that would be more positive for a labral pathology. So as O'Brien has done, or as other people have done the O'Brien's test, you can see that the sensitivity and specificity of this test by itself is not a great indicator of labral pathology. It's a real easy test to perform, but it's not always as perfect as the original construct. And I think this is an important point as you read about tests, and it's only come out new, and initially there's only one test. You really want to have those additional studies that actually support that diagnostic test is valid and consistent. So an N of 1 study is not necessarily wrong. It just might be stronger and more supported as more studies are done. So going back to the Walsworth study, this table's small, I apologize for that, but basically if you look at the positive likelihood ratios, that any individual test isn't fantastic to identify a labral pathology nor rule out a labral pathology. The anterior slide test was probably the best with a 2.25 positive likelihood ratio. But what they did is they started combining those tests, and they found that if they had a history of popping and clicking in all three tests, their specificity was 1. So if they were positive with all of those, they were very confident that those patients would have a labral tear. They were found to have a labral test. Even if they had a pop plus one of the tests like the anterior slide, or two of the tests like the anterior slide and crank, they had really good specificity. So they were good for ruling in a labral test. But without the history of the pop, just looking at two of the tests, the active compression and the crank, the specificity was about half. And so I think it's important to remember that the history that the patient presents with these labral pathologies are really important as you go through your assessment, as you do these combinations of tests. After that paper came out, Dr. Kibler published this paper called the Modified Dynamic Labral Shear. This is a passive test also. You elevate the arm in the scapular plane up to about 110, 120 degrees. Then you externally rotate and bring the arm posteriorly into the frontal plane. So you're bringing it up and back. And then you apply an axial load as you adduct the arm. So you apply a axial compression load and then downwardly adduct the arm to shear the humeral head against the superior posterior labrum. So that's called the Modified Dynamic Labral Shear Test. It's really the dynamic labral shear test in the literature. Most people don't use the word modified. The likelihood ratio of finding a positive test by this one study was 31, so that's very high. But again, as I just said a moment ago, this is only one study, so other people need to study that. Sometimes I have found that if I have the person scapularly retract their shoulder, that sometimes relieves their symptoms, which would suggest to me that Yes, they might have a labral pathology, but now it gives me some insight to, hey, maybe I can reduce his symptoms or her symptoms by working on scapular motor control and getting the scapula out of the way with overhead activities. So these were all the shoulder tests that I presented. Hypomobility, you're really going to look for active and passive range of motion. In particular, for adhesive capsulitis or stiff shoulders, you're looking for passive range of motion that's 50% of normal. Hypermobility, AC joint separation, visually you can see that. The apprehension, the relocation, and the release test are for anterior instability. The jerk, posterior instability, hyperabduction for inferior glenohumeral instability, and the Beighton scale for generalized laxity. These tests would be appropriate in a person that is suspicious of having some trauma or having some shoulder pain, and I think it's really important to do these anterior and posterior instabilities and hyperabduction test to rule out that they don't have an instability incident. So when you assess hypo and then hypermobility, now you're confident that they don't have those. You can start to look at the more common. I think if you reverse it, it makes it a little bit more difficult to assure that you have identified all the possible causes. Subacromial pain is a diagnosis of exclusion, meaning I want to rule out all these other things. And now I'm going to look at rotator cuff pathology, tendinopathy, and labral pathologies. So rotator cuff tears are going to be associated with older individuals, people with night pain, and then have positive lag signs. Those are the most clear-cut indications of a complete rotator cuff tear. A partial tear or a tendinopathy are going to be those 3 of the 5 tests of painful arc, positive Neers test, positive Hawkins, weakness in external rotation, and weakness in elevation. And then labral, we're looking for a history of popping and clicking, really critical in those patients. And then active compression, or the O'Brien's test, anterior slide, and crank. If the history of popping and clicking is there, plus the active compression test or the anterior slide, you have a pretty good comfort level that they might have a superior labrum. The dynamic labral shear test is a newer test that wasn't part of that original study, but is also by itself has some good evidence to suggest that it's good for identifying people with superior labral tears. So to summarize, active range of motion tests, both static and dynamic structures are being evaluated. So when you think you're suspicious of a cuff tear, you have to do both active and resisted type exercises. When you're more suspicious of a ligamentous or a labral pathology, passive range of motion tests are really important. You are potentially irritating tendons, which are musculotendinous structures, but at the same time your focus is going to be more with active or resisted exercises, aggravate those. Resistive range of motion is going to test the integrity of the dynamic system. So that's going to be your motor output. So your rotator cuff and other musculature has to be evaluated. So when you're thinking of those. So in the shoulder, you have to keep in your mind active range of motion is where you start. Passive range of motion is going to help you identify if there's a capsular adhesion or if some of the static stabilizers are damaged. Resistive range of motion is going to help you identify tendinous, musculotendinous damages, and to what degree will depend on how weak they are. Pain obviously has an influence on that. So some people have a lot of pain perception or pain experience that will limit their ability to generate much force until the pain goes down. So that can be a tough separation. Thank you.